morning. I'll start with my professor, Satyasekaran sir. And Pankaj, you know, I cannot name each and everyone. It's a great pleasure to be here. I personally thank Dr. Anayappan, who see to that you must be here for this day. It's a great pleasure, sir. I remember the days when myself, Priya, were doing the national conference, APSM, and just remembers all those days. In fact, my view or vision is that we should again integrate that IAPSM, IPH one day. If that is going to happen, definitely we'll be there to host, support whatever things you want. Definitely we can do that. So with that, I'll go to the subject. Sorry, I don't have a PPT. Just I'll discuss whatever experience which we learned. In fact, Lograts Mari, we have get into this Directorate post, the peak of COVID, where managing this COVID, followed by COVID vaccination, it's the biggest thing which you have done. And in fact, it is the biggest learning for a public health person. See, what and all we read in the book, we could able to implement it. And what and all you talk about team, multi-sectoral coordination, we could really prove in the field. So that's a big knowledge again. Very good. And Lograts, definitely, since the topic is little wider, he has given both the communicable and non-communicable disease. We can talk anything on the earth and say it's related here. Anyway, it's another advantage for me is that even if I miss out something, I say, since the time will I couldn't do it. That's unfortunate. And you know, since you have around 20-25 minutes, you please stop me whenever you feel. Taking clue from your Lograts, see the COVID, the way in which we handle will give you a way in which we need to handle the entire communicable diseases. See, we started with the identification. So the identification is done at the earliest, which is the most crucial thing which is responsible for your diagnosis. See, unless and otherwise you identify the antigen or a pathogen, it will be very difficult for us to establish your diagnostic test. So that is what quickly done in a COVID. We could identify the source, the antigen. Based on that, your test will come. And in fact, before this, RT-PCR was not heard in many areas of medical college except in the microbiology. After some time, we could see the RT-PCR. In fact, in Tamil Nadu, we developed the capacity of doing more than 30 lakh tests in a day. So that is the capacity we could able to do it. Followed by all your rapid kit, sensitivity, specificity, all those things that come. In fact, linking this with your clinical features, what we call as an epidemiology, given us many non-pharmaceutical interventions. So before that, we used to talk about only masking at the most. The masking, hand washing, the social distancing, the effect, implications, everything we could able to by linking your epidemiology, microbiology and your clinical features. This is the way in which we could design your isolation, quarantine and also identify the implications of your comorbidity, the implications of non-communicable disease on a communicable disease. See, in fact, it has given a wide spectrum of range in which a public health person or a community medicine person or whoever who wants to do something good to the community can interact or learn from this. And the variations which we could able to pick up in through WGS is clearly indicate where we need to panic, where we need not to worry. See, with so many variants, initially we were worried whether it will have an impact. So whether we need to worry, whether we need to step up our activities. But while we are able to identify the variants to your one genomic sequencing and link it with your clinical features, mainly two things we have identified. The rate at which it spreads and the severity at which it gives. How many more admissions, how many more deaths. This is the two critical things from the public health point of view. Once you are able to link it, or Sejikapram and the Omicron is coming, no one is bothered about it. The initial fear has gone because we could able to prove things scientifically. So this is not all possible because of these two interventions of linking your genomic sequencing with your clinical features. if you are able to adopt all these things, all communicable disease can be definitely get under control. In fact, we could able to do many things, but the real challenge is that there are many more things to come. So it is not only one COVID. There could be any emerging, any re-emerging diseases. Anything can become a pandemic level, and we need to handle it. In fact, this COVID has given us the way in which we can prepare our system to handle any emergency. See, after some time, it is not going to be disease specific. Even though certain treatments will be particular to the pathogen, but most of the way in which we need to handle in a community is more generalized. How you can prepare your system to handle it. So this way, it's very good we can do it. And two other thing which I want to talk it here is that unless and otherwise to take care of your health, the global is not going to survive. See, the COVID has shown us that it is your health is affected, your business is going to affected, everything is going to affected. And if it is happening from one part of the globe, it can spread to the rest of the country in another 2 to 3 hours. That's a time in which it needs to travel. So the global has become a small village. Anything can happen in any part of the globe can spread to us. We need to prepare. The international health regulations which you used to read, we could able to implement only during this pandemic. So with this knowledge, yes, we could do many things good. For example, your malaria, filarias, and leprosy, which used to have a vertical department, now it has become horizontal because we have come to a level it is no more a big public health problem. Say, for example, the malaria, which used to be almost 2 to 3 lakh cases, thousands of deaths, now it has come to a level where my 33 districts were already declared no indigenous case. And only 5 more districts are there. Please. So only 5 more districts are there. So these 5 more districts we can anytime cover it. See, 33 districts we are keeping away from all indigenous cases. The 5 more districts also we could able to focus. See, in fact, your indoor residual spray which you used to study in the book, we are doing it in Ramanathapuram. See, if you are able to focus your attention, definitely we are very sure that maybe in another few years, these 5 districts also can be away from your malaria. The similar way, your filariasis, we are the one who started your multi-drug therapy long MDT in Kadalur, we have piloted, sir. Now MDT is over, we call it task, the assessment survey is over. We are in the process of documentation where we can even declare filariasis out of Tamil Nadu with the document. It needs more documentation. We could have all evaluation done. The documentation part, we can do it. But the challenge here is your migrant population. In fact, I have a recent history in Tuberculosis, a small pickle company. People are moved from different parts of the north, and if you able to test them a night blood survey, still it's a big challenge. Bombs are coming in mass, big numbers. So the challenge remains there, but we have reached a level where we can get certified for elimination. Similarly, leprosy, yes, now where it used to be a big challenge, now it's around 4,000 cases in a year we are getting it. But the challenge here is that the old cases, the leprosy cured but disformity is there, it's becoming a big challenge. And Tamil Nadu government started providing all rehabilitation, including a contributory pension of 2,000 rupees every month. But this is another state, but the challenge here is that because of the long incubation period, still we continue to get a child cases. So with all challenges, we are still in a thing to do it better. At the same time, now we are getting your MPOX and Nipah in different way. See, the MPOX, the suspected case, we had from Kerala, and the contacts also we could trace it. And the similar way, Nipah also, we had a challenges. But with all this, there are positive stories also in non-communicable disease. As said by definitely Makale Tedi Marthum, we could do around 92 crores of line listed beneficiaries. So no other state in the country could have the line list of non-communicable diseases. It is the highest number. And the point here is note that it is not one of the physician or a professor who could able to do it. Mostly it is done by an volunteers. The community involvement, which made us think to happen, this is the line list, and this is the positive side, but we have so many other things to do. So that I have discussed. And jumping back to again to communicable disease, I said COVID has given experience. We have a good story. We have a challenges also. The combating this is mainly through a surveillance. See, unless and otherwise you step up the surveillance, nothing is going to happen. See, we need to pick up those cases at the earliest possible. Right now, we have an IHAP portal where it's very good portal. In fact, we can have a live dashboard of what is happening across the country at any time. In our state, we have almost 4,000 institutions are already registered and they're sharing the data. Everything is good except that it needs to be done on a daily basis by every institution. So this is very critical. Unless it is done on a daily basis, we tend to miss the cases. This we are trying to strengthen it. And another two area in addition to the surveillance is your environmental surveillance, your wastewater surveillance. See, this has got a huge potency and it is of, a little effort. If you are able to create a system, we can do it. Wastewater surveillance, environmental surveillance also, there are many things can be done. Now we can get the air pollution data through Pollution Control Board, but the IT has enabled us where we can even able to generate your pollution rate automatically and integrated in the system. See, this is all the next area where we can explore and we can get it. And another area, environmental, is related to your meteorological data. See, the big communicable disease which you are talking about, the dengue, it's related to your meteorological data. In fact, we have a strong evidence of correlating your rainfall and the temperature with the dengue incidence. Almost 10 years of data we could able to pick up, and in fact we can able to even localize which part of the state in which month we expect the case. So this is the environmental surveillance. This is very, very critical for your communicable disease control. Unless this mechanism is set up and everyone is contributing, communicable disease control may not happen. And if you go a little specific, in fact, so Bhargav talking about your TB, maybe I will take from TB itself. All good. Notification is better. You have a complete drug regimen. In fact, we are the one we started your TB preventive therapy first among the rest of the states. It's going. But the challenge which we had is the availability of the drugs. Even for the regular availability, there was a challenge for almost a year. We need to purchase locally. But again, challenge is that even if you have money to purchase, the availability of drug is the big challenge. The pharmaceutical producers are very, very limited. And when there is a market demand, the price will rise. Unfortunately, the poorest of poor will not get the drug, even if he has got money. So this challenge is there. And the BPL regime, which you were also talking about, is still yet to roll out. We are preparing for it. And the adult BCG vaccination, which she was talking about, we are ready to roll out. As a government level, we are ready. It's mostly based on the consent only I want to do it. The challenge is that little bit of adverse events, which was happened in the adult BCG vaccination in few states, has given us little bit of jitter in the experts. So we couldn't be able to move forward, but the two things are very clear. It's purely based on the concern and it will be implemented on a program basis. And the question sir was asking about X-ray. It was part of our TB prevalence survey. The TB prevalence survey we did for almost 1.5 lakhs in Tamil Nadu. We have tried all the medicines simultaneously. It's not only symptoms, sputum, and also we want to take up an X-ray. So just to see whether you are missing out anything. In that only it has come out as a finding there. Now we are trying to devise a little different protocol in which we don't want to leave anyone. See, for example, if you are symptomatic, our original microscopy still holds good. though there is a lot of challenges in saying the sensitivity, specificity, the upfront NAT is fine. It has got more sensitivity, but the challenge is your cost. See, the microscopy, I can do it for 10 rupees, but if I want to go for an upfront NAT, it's 1,000 rupees. So that is the challenge. See, you can have a sensitivity, more specific test, but the price. In fact, we are going for a one more level. RT-PCR is the platform. See, once this platform is there, we can explore with any pathogen. It could be viral or bacterial. Any pathogen, how we can use this as a platform, RT-PCR is another area. So, adult BCG, TPT, Dixie, see, all are good. The challenge is that sometimes the drug availability is one challenge. But with all these things, the big problem which we face in Tamil Nadu is still the mortality rate is high. 6% of mortality is still happening. But this is the big challenge. And we had one more intervention for this, what we call as a differentiated care. See, even though it is we are the one state which we have talked about, it is an ambulatory care which we can go take it door to door. But now we feel that there are certain group of people who need some hospital admission. See, unless and otherwise you take care of them, the mortality is not going to come down. That is what Suresh also talking about. Yes, it was there. Now we could able to prove with the certain clinical symptoms and signs, unless they are admitted, the outcome is very bad. Even after completing the treatment. So if he is not going to die for TB, he will be dying for other things which is correlated. So this differential can be do it. This is about TB. And dengue, yes, among all other vector diseases, this is becoming a bigger and bigger problem. I used to get not less than 150 cases in a day. So far, almost 18,000 cases in this year alone. This we need to see with the population we are handling. See, we should not see this absolute 18,000 is a big number. With the population we are managing, this number is an expected number. In fact, in this season, we expect a surge. We could be able to definitely stabilize or bring down. And the area which right now we are concentrating is your prevention of your mortality. See, again, previously the so-called hemorrhagic or shock syndrome, the kids used to die. Now we are trying to keep it at the lowest possible. In the last 10 months, it's only 7 deaths are directly due to dengue. Though the cases were rising, we could able to do it because of all clinical support. Able to do it, but still, the main idea here is that we need to pick them cases at the earliest possible. Avoid them taking your your prescription over the table, and if there is a little bit of symptom coming down, we should staying away or taking your work. In fact, the third or fourth day is the biggest risk day where the deaths are happening. See, in the more information should not lie with us. It should reach the community. See, unless and otherwise this information reaches the community, they are not prepared. As usual, their treatment finally become whatever effort you put in, the death will be. This is the area which will be focusing on the dengue. Another communicable disease which needs your attention right now is your rabies. So almost 38 cases in the last year, 100% fatality. But again, it's a multi-sector driven. See, health sector, in fact, it's a sufferer. See, I spent not less than 14 crore for ARV vaccine alone. And after some time, it will not be sustainable. See, if I see my data, which I used to have 2 to 3 lakh dog bite cases, now I am seeing around 6 lakh cases in a year, 6 lakh dog bite cases. See, it's not only the rabies, the road traffic accidents happening because of the dog chasing is very high. And we are not against dog lovers. See, there should be See, we are not against the dog lovers. There are two things we should be very clear. See, everything should be a way in which it has to be done. If you are a dog lover, adopt the dog, get the license, get the vaccination, nothing wrong. But our love is only throwing the food in the street and making this a community dogs growing in more and more number. When there is a challenge, it is the one which chases us. So if you are really a lover, adopt, vaccinate, feed them. And another area is the ABC. which we entirely depend on the local body. The cost at which it has to be done is there. But again, over a period of time, unless and otherwise the solid waste management is taken care, the ABC also will not be sustainable. See, that's the biggest source for these people to survive. Whatever number of ABC control measures you do it will not maintain. And again, here also, it need to go on a bigger level of mass vaccination with your rabies vaccination for the animal. And also, we cannot talk about mass castration, but still, we need to bring down a population to a level where it's manageable. See, the way at which it is growing, it became unmanageable and sustainable even if you want to do it. Here the technology is there, but everyone, including the common man, to understand the implication, the way in which they are contributing to it. So, everyone has to do those. And another area which I need to talk on this communicable disease is your AMR. It's really a big challenge, and every one of us is contributing. See, what is happening in the animal veterinary field or in the plant pathology, it's having a big impact on us. See, the regulation should happen across the system. So this is one area. And hospital-acquired infection, this I again feel as a part of your communicable disease problem, it's huge. The way in which the persons need to spend after the intervention in a surgical area, it's very, very high. The duration of stay is increasing, the cost of care is increasing, and further you are going to transmit this resistant bacteria or virus to the community. See, unless and otherwise every one of us start understanding this implication, it's going to be a challenge. In fact, I used to say, suddenly if all your antibiotics are not working, imagine the situation. What do you do? Imagine the number of people who are going to die, at least those on ventilators. So there's another area. And if you are going on talking about this communicable disease, finally you land in a 1 year. See, what is happening in the community is having your impact. Whether it is plant health or animal health, it is directly having an impact on us. See, the nutrition which is depleted in the environment, it's getting reflected in your plant, and ultimately again to the animal, where you depend on milk and meat on the animal. The milk and meat production is going to come down, and finally the reproduction is also going to come down. See, this is our economy. See, in fact, our Indian economy, where it is dependent on the agricultural and one or two cattle economy, when the production, the reproduction, the production, if it is coming down, it's going to affect the economy of the entire rural folks. And the implications we will be going for a processed food again. See, because the availability has come down, we want to say whatever the available, you will go for a processed food and ultra processed food. Again, it will go for a mold, salt, sugar, everything, you will end up in a communicable disease. See this linkages. We need to intervene and forget about the immediate impact. In fact, when the heat test was there, one of the first cases reported was from Savita. I don't know who was there. First heat test. See, we had never imagined that people will die of heat in Tamil Nadu. It has happened. The same way, when the floods are there, almost every city. Chennai and the unexpected thing last year happened was in Thoothukudi and Tirunelveli. It was never. 2 days now, it is the time. Now your Madurai and Kanyakumari used to have, but Madurai is flooding. It was not there. Thoothukudi flood, we could see it is not only the direct impact, the river it was flowing on. There are so many PHEs were totally submerged. And water supply, we could not restore it for many years. It damaged the system. Chlorination, matra, boiling, it's all. See, once the challenges are the natural resource, such a big force, we cannot handle it. So we need to use it to the minimal need. If you are using for the green, we are going to suffer. And it's not only communicable and non-communicable disease also. Now I'll slowly move to the non-communicable disease, because the One Health, even though we all know it has got an implication of the communicable disease, we now start understanding it has got an impact on the non-communicable disease also. The way in which your mental health is getting reflected, it's because of your environment. And the way in which the response will be a different one. So similar NCD. And since you are already talked about MDM, I'll start with the NCD there. NCD, yes, I said 1.92 crore. It's a big number. No one has done it. This is a positive side. The negative side is that still there are certain people who are not willing, even in the IRS building, to do the testing. And there are certain people, even though we do a door-to-door screening, not willing to get it done. This is one part. The second part is that we give drug free of cost. We deliver the drug to their house. And in fact, the cost saving, the out-of-pocket expenditure reduces almost 3,000 to 4,000 rupees every month to every individual. But the challenge which still I face is your control rate. See, unless and otherwise we attack this control rate, your complications are not going to come down. Your mortality is not going to come down. See, the problem is the ultimate goal is that we should attain the control rate. Even though we have attained the World Bank control rate, which we call it as a DLI, we reached the DLI, we got the loan sanction. But when you see an again second step survey which you have done, the control rate is the still bigger problem. And until otherwise you are able to handle it, in fact, our mechanism is you come to a PHC every 3 months, we do all the tests free of cost, give the drug, but still it's a challenge. The one area which we need to improve is your protocol, the SOP. See, every physician want to treat every individual in a different way, maybe it's right, but in a bigger setup, when you are handling crores and crores of people, we need to follow it. See, the next generation should see that this is your first line of drug, this is your second line, this is how you need to measure. Unless if it is working, you cannot just jump over it. There's a way in which we can start, the way in which we can progress. Second area, once you have done this control, though we have a list, we need to monitor on your complications. So the complications, retinopathy, neuropathy, and nephropathy, it's become a big problem. Your chronic kidney disease is the highest utilizer of insurance money, almost 100 crore in a year. People suffering is another big problem. The availability facility is one. So almost 2 to 3 days in a week, they need to come for a dialysis. See, imagine that person's problem. Also, the family has to suffer. Someone has to take it. We promoted the peritoneal dialysis. It's one of the good intervention. Many states are doing it. But unfortunately, there may be a little bit of commercial interest. I am not able to crack that still. But the choice which we given is whether peritoneal dialysis or hemodialysis, we start with the nephrologist, the treating person. We are given his choice, but this is the way it has to go. At least, in fact, I used to imagine it's by default it should be peritoneal dialysis, then only it becomes sustainable. See, otherwise, this hemodialysis machine made, it's become a big challenge. Second, to do this complications, now we started doing a small urine testing in a PHC itself, where simple testing, where we can able to pick up those suspected cases at least. Instead of doing it for EPG or creatinine for everyone, the salt positive, now we have a GPR rate, we are able to calculate it, we can shortlist. For a short time, within 6-7 months of introduction, we could able to pick up more than 3,000 cases. See, these are the undiagnosed cases, CKD. Unless and otherwise you test it, it may not come down. So this is where your public health is there. This is about CKD. The similar way, your hypertension, if it is not controlled, your cerebrovascular disease is the biggest challenge. Now, cardiac problems are now quick intervention, PTC or CABG. Somehow people are managing. But the cerebrovascular accident, when you're being hemiplegic or paraplegic, it becomes very dependent. For months together, they need to give them a support physiotherapy. Though this is also part of the MTM, our team able to give them a services. But goal here is that the family should take care. Unless and otherwise, this services become home-based, where the family members take care. Again, this is question of sustainability. In வெளியே போய் physiotherapy கேட்டீங்கன்னா 2000 ரூபாய் கம்மியா வர மாட்டாங்க. And it's not that one day or 2 days. We need to take it for a continuous period. This service, this knowledge should go to this. Then your amputation. How we can prevent the amputation. NCD together. Thank you. Teacher. See, amputation, we have scheme. See, what we are more interested in is that at least the visible ulcers, if you are able to pick up and manage them in institutional care, all your microsurgery, whatever it is, definitely we can save the amputation. It's not only that we can give another artificial limb or a functional limb with under insurance scheme, but again the suffering, the continuation is the problem. And we have another finding. Once they are going for an amputation, there is a high probability of these persons going for other complication, other system, because of your vascular damage is already happened. So numbers are good, but we need to focus on the complications which is going to happen. And it is not only here, the another area is your cancer. Though we talk about all cancers, we focus only on 3, your cancer breast, cancer cervix and oral cancer, visible, easy to diagnose. Almost in 2015, we could able to do the screening, opportunistic cancer screening. We got a good success. Now we changed our mode into an organized cancer screening. That is, we will identify a person in each and every area, and we see to that everyone gets an invitation, whether you have a symptom or not. All 30 plus they should come for a screening. It's a good, we could able to take invitation, but the return which we are getting is limited. So only around 40 to 50% of the people we given the invitation was coming for a screening. So screening there's a challenge. And once you've done the screening, we need to go for a further confirmation. There's a huge gap between the suspected and the confirmation. When you ask them to go for a further assessment, it's almost 20 to 30% only people are there. So this is where your early diagnosis is missed, and they come with the late stage, but the treatment is a challenge, the cost is a challenge. This is another area which we need to concentrate. If you cut to another big problem is going to be your NCD, it's a mental health. The suicidal rates are very high in Tamil Nadu. The adolescents are the one who are easily getting affected. It is not your economic pressure, it's not your educational pressure. And now the easy availability of your drugs and alcohol is another challenge. We need to focus on this. And your non-alcoholic fatty acid, this is simply raising. The cost of liver transplant is very high. The success is a big challenge. So these are the other areas on non-communicable disease which we need to do it. Finally, see, to have a bigger thing, we need to have a full data together. See, unless and otherwise we put all the data together, we cannot have a big plan, we cannot have an impact assessment. For this, it's a time we'll go for a digital mode. National Digital Mission now advise go for an your ABA ID, all health facility as linkage and health personnel provider. If you are able to link everything, including the private, definitely we can have a better data which everyone can share, everyone can view. This one area. Second is your HR. See, ultimately, whatever you want to do it, you need a qualified, sufficient manpower. But our current experience, which says is that it is not only the experts, but even the generalists, even those community people are more critical here. See, the empowering them with the health literacy and empowering them to report is much, much easier and more impactful. See, for example, the IHIP portal, we open to public. So, basic symptoms, signs, fever, jaundice, they can also report. So, once they start reporting it, we could able to identify the place, we could able to do it. In the similar way, for a non-communicable disease also, the lifestyle modification is the biggest thing. The way you exercise, the way you eat, this is more important than the way you take them. So, this is the community role is there. And the cost, again, your health financing. See, ultimately, this is where most of the countries will face problem. Cost of drug, if you are free, now we are more focusing on a secondary and tertiary care. See, I have more money for treating a PTCA for CABG, But I cannot bring down the CABG unless I control my hypertension diabetes. See, unfortunately, our investment is going more on the tertiary care, but where we can have a more impact on the primary care. So this area we need to shift it. The similar way I used to say, viral rendu paracetamol, rendu antihistamine kudutha pogum, but unfortunately we land up in a pneumonia, spend huge money on a ventilator. And finally, for the youngsters, lifestyle modifications that go. Whether it's for communicable disease or non-communicable disease, unless and otherwise you take care of what you eat, the way you keep your mind and physical body free, exercise, nothing is going to change. See, ultimately, if something happened, we are going to face it, and the complications, if you are untreated, is going to happen. This is an area which we need to focus, and I will close saying that it's a time the education and the implementation should come together. See, otherwise, if it remain, it will remain and it will not be useful to anyone. See, it's a time we start integrating at whatever level possible, even at a smaller level. Unless this is happening, things may not happen. See, Bharatraj, points, what is the issue and challenge in TB, I can list out. But this knowledge may not be there in an institutional basis. So this is the place where we need to talk to each other, understand each other, work with each other, then only the health of the state, health of the community can be taken care. Thank you very much for the opportunity. Thank you.